We're really excited today to be presenting our third webinar focused for APRNs called Empowering APRNs in Navigating Billing, Coding, and Reimbursement. I'm just going to review with you the continuing nursing education information on how to receive your CNE. To receive 1 hour of CNE, participants must attend this live webinar presentation in its entirety and complete a post-webinar evaluation. An email with the evaluation will be sent to you post-presentation, which must be completed by no later than October 19th of 2023. You will then be provided with a certificate for your records. The ANA is accredited as a provider for nursing continuation professional development by the American Nurses Credentialing Center's Commission on Accreditation. And we're also approved by the California Board of Registered Nurses. I'm really excited today to review the objectives of our webinar, and then I'll present our two guest speakers. So today we will be discussing the significance of APRNs understanding billing, coding, and reimbursement processes and the reasons behind their importance. We'll define the key components and processes for reimbursement. We'll recognize the key public policies that govern how APRNs are paid and how healthcare delivery is financed. And we will identify information and access tools for engaging in policy processes related to provider payment and healthcare financing. So today, our first speaker is Carrie Miller. She's a hospice nurse practitioner and the current Vice President of Compliance, Revenue, Risk Intelligence at Jefferson Health. Note the disclaimer that the content she presents today is independent of views and policies of the Jefferson Health Network. There's no proprietary or confidential information or data that will be disclosed. Our second speaker is Lisa Stan. She's the Director of the Policy and Regulatory Advocacy, Policy and Government Affairs with the American Nurses Association. So I'm going to go ahead and hand it over to Carrie.
Thanks, Elizabeth. Hopefully everyone can hear me okay. I'm very excited today to talk with everyone about reimbursement and nurse practitioners. So as Elizabeth said, I am a nurse practitioner, but I understand clinical documentation and coding and billing because I spent about 12 years in the healthcare consulting side, focusing my time and energy in that area before transitioning into my current role at Jefferson Healthcare. So I think it's good for us to understand where we are today and look back to see how far we've come. So for those of you who may or may not remember, the first nurse practitioner program was founded in 1965 by Loretta Ford and Henry Silver at the University of Colorado. But nurse practitioners weren't getting reimbursed for their services during that time. And we didn't get reimbursed for our services really until almost 30 years later in 1997 through the Balanced Budget Act. But if some of you have been around for a long time, you'll know that a lot of states were pretty restrictive in terms of nurse practitioner scope of practice in the 1990s and the early 2000s. So again, most nurse practitioners, even though we could directly get reimbursement for our services, many of us were actually not. But today, 2023, we've come a long way even from 1997. There are over 355,000 of us in the United States currently practicing. Most of us see Medicare and Medicaid patients. That's why it's so important that we understand how we get reimbursed for our services. And a lot of health systems are moving towards different reimbursement models for nurse practitioners. And a lot of them are very similar to how physicians get compensated, which is through a work RVU model. So it's imperative that you really understand clinical documentation, coding and billing, and how you get reimbursed for your services. Of the nurse practitioners today, about 80% of you are primary care or family practice, followed by acute care and adult, which is what I am, psychiatric, and pediatrics. So whether you practice in a skilled nursing facility, you work in an emergency department, an inpatient or outpatient setting, it's so important that you understand how your services drive value and in return, revenue. Today, I will be focusing on, at a very high level, and I say very high level, aspects of reimbursement, what needs to be in place to be reimbursed, and the clinical documentation to support the why you are reimbursed. At the end of the day, the ultimate responsibility to ensure that you're getting reimbursed and paid for your services lies with us, lies with you. So let's move on, and we're going to talk a little bit about compliance, which is where I've spent the last couple of years of my healthcare career. Elizabeth, do you mind moving to the next slide? So there are 4 key laws that as a clinician, you should all be aware of. The first one is related to fraud, waste, and abuse, and it's related to the False Claims Act. So the False Claims Act basically says it provides monetary penalties that can be imposed upon a healthcare provider who is knowingly and willfully, just remember, knowing and willfully, makes false statements or misrepresents in connection with filing a claim seeking reimbursement from a federally funded program. So what does this mean? So in layman's terms, what this really means that if you're a clinician and you billed a federal payer for a service that didn't occur or billed for services whose documentation didn't support it, you could be in violation of the False Claims Act. Examples that I've seen with False Claims Act out there is Incident 2 billing, issues with Incident 2, teaching physician guidelines, overcoding or upcoding, depending on how you say, how you want to phrase it, or how your compliance department phrases it, or coding department. Billing for services that completely did not even occur, or billing for services that didn't meet medical necessity guidelines. So those are a few examples related to the False Claims Act, or for those of us, fraud, waste, and abuse. The second law you should know about is the anti-kickback statute. So what this says is it provides civil and criminal penalties for individuals or entities, again, that knowingly and willfully offer, pay, solicit, or receive remuneration to induce the referral of business. Now, remuneration can mean some sort of financial value, but it can also mean you're providing a service that in turn could turn into some sort of financial value. Again, at the end of the day, this law really wants to ensure that any medical decisions that are made are in the best interest of the patient, and there's not any financial incentive. So as a nurse practitioner, really important to be aware of the False Claims Act and the anti-kickback. The third law to be aware of is the Stark Law. And so this one provides criminal penalties for individuals or entities that do not adhere to the regulations regarding financial arrangements between referring physicians and entities that provide health services payable to federal payers. This is really around physicians and their conflict of interest with other entities. Again, making sure that that medical necessity comes before any financial gain. It's really related to physicians. I haven't seen it where it's been tied to anyone who is not a physician, but a good law to be aware of that's out there. And the last statute to be aware of is the exclusion statute. This is a really important one. It requires the OIG to exclude individuals and entities convicted of offenses from participating in a federal program. So for those of you who practice in a healthcare setting, your HR department, compliance, internal audit, they run the exclusions list on probably all your new providers annually and even third-party vendors. But if you joined us today and you have your own practice, you should be running the exclusions list on anyone that works in your practice to make sure that they haven't been excluded from the OIG to participate in a federally funded program. A couple other compliance considerations that I like to talk about when I talk to my clinicians. to just mention here. The first one is about clinical documentation integrity. And I'm going to talk about it, not the next slide, but the slide after. It's really important that your clinical documentation reflects the services that you have performed. And I'll talk about why that's so important in a couple of slides. And the next piece is copy paste. So copy paste. Electronic medical records, they've done wonders. We all know they've done wonders, but they've done a lot too when it comes to notes, right? We have note bloat. We all know about note bloat, and there's a lot of copy paste out there. The E&M guidelines, which changed in 21 and 2023, tried to decrease note bloat and decrease the amount of documentation that we as clinicians need to document on patients. But I just want to bring it up, as a lot of healthcare organizations develop policies around copy paste, and you really want to make sure that you're documenting on that date of service what's going on with that patient. So two kind of sidebars just to talk about from a compliance consideration. Elizabeth, next slide. All right, now on to the fun stuff, the fundamentals of billing. So we're going to really start at the basics. So for those of you joining us, hopefully we're all credentialed within whatever specialty we're currently practicing. But if we're not, the key piece is you need to be credentialed within whatever specialty you will be practicing. Once you're credentialed, as we all know, we all go and get our state licensure, right? So we're all licensed now as advanced practice providers, nurse practitioners in the state that we're practicing in. Then we need to understand our state laws, rules, and regulations. Every state is different. Some of y'all are practicing in states where you can practice independently. Some of you are practicing in states where you have a restrictive license. So really important, once you get licensed, to understand what your state laws, rules, and regulations are in terms of your scope of practice, because we have the federal government here, and then we have the state here. So a lot of states can be more restrictive, right, in terms of our scope of practice than the federal government. Why I talk about this is, depending on your state, you may need to get a collaborating agreement with a physician. Even in independent states where you can practice independently, you still may need a collaborating agreement. So one of the key pieces that you need to ensure that you have from a compliance standpoint is to make sure you have a collaborating agreement with a physician that outlines what your scope of practice is. Some states, when you go to get your DEA license, they may even require for you to have a physician on that DEA license. Key things you need to be aware of. The next piece, credentialing. This is the fun one. So you need to make sure that you get credentialed with any payer where you will be billing your services. So you need to get set up with a Medicare NPI number, and then any payer for which you will be direct billing for your services, you need to make sure you get credentialed. And it's one of the top things you need to make sure that either your credentialing department does, or if you are going to open your own practice, that you do right away. Because it can take, I've seen it take 6 months to get a clinician credentialed with a payer, at least 3 to 6 months. It can take a really long time. So it's very important that this is one of the key things that you do at the beginning. Another key piece when I talk about ensuring that you're credentialed with your payers, that I don't think most nurse practitioners end up doing or even know about, is you need to understand your payer contracts. Medicare, from a reimbursement perspective, pretty easy, right? Medicare allows us to directly bill for our services. We get reimbursed 85% of the physician fee schedule. Medicaid, not so simple. Commercial payers, not so simple. So Medicaid's come a long way over the last 10 years. I think by and large, I'll say the majority of state Medicaids, because right, it's the state health insurance, do reimburse for nurse practitioner services, but you really need to know if your state doesn't. The other piece comes with commercial insurance. So commercial insurance, again, own rules and regulations when it comes to who they reimburse and for what services. So I've even seen where commercial insurances, guess what? They won't reimburse for nurse practitioners outside of the primary care setting. They will, that's the only place where they'll reimburse for nurse practitioner services. So it's really important that you understand your payer contracts, because if you start billing for your services and all of a sudden you're not getting reimbursed, you need to understand why. Is it because they're not reimbursing for nurse practitioner services because you're practicing, say, in an emergency department setting and they don't recognize that setting? And now you need to figure out how can I get reimbursed for my services, which I'll talk about in a couple of slides. But really important to understand your payer contracts, because again, you need to get credentialed with your payers. And then if your payers don't reimburse for your services, you need to understand, that they don't reimburse for it, because you need to understand why there may be a gap in revenue tied to that payer. The other piece to talk about when it comes, again, to ensuring that you're getting reimbursed for your services is you need to make sure that if you're working in a health system, or even if you're working and you have your own independent practice and say you want to have privileges at a hospital to admit your patients to or see those patients, you need to make sure you get credentialed and privileged with that health system or that hospital. Really important, because again, you will not be able to bill for your services unless you are credentialed and privileged to practice in that hospital or in that health system. So that's another key aspect. And finally, one other thing just to note here is that we have federal rules and regulations, which are up here. You have your state, which is more restrictive. And then you even have your employer or the hospital bylaws or the med staff bylaws. And they may be even more restrictive than your state in terms of what your scope of practice is. So again, really important you understand your hospital or med staff bylaws if you practice in a health system or an academic medical system, to understand that piece. One more piece I want to add here. If you work in a health system, you currently are not billing for your services, there may be a reason in terms of why you're not billing for your services. I'm just going to mention this really high level, but if you work in a health system and you don't bill for your services, it could be because your salary is coming from the hospital and that you're a hospital employee, and therefore your services are being billed to Medicare on the hospital cost report and not from the physician's cost report. I could have a whole 30-minute discussion about this, but if right now you are not billing for your services and you work for a health system, I would encourage you to go to your finance department or go to your compliance department to try and understand, or your executive advanced practice clinician leadership team to understand where your salary lies. If your salary lies on the hospital cost report, this is why you cannot bill for your services. You're going to need to figure out how to move it to the physician cost report if you want to be able to bill Part B or for Medicare services or under Part B. So that's just a little nuance. Those of us, I grew up from a clinician standpoint, and my salary came out of the hospital. I was paid through the hospital. So I never billed for my services because I was always on the hospital cost report. So just a little bit of a nuance there. I think a lot of health systems are moving advanced practice clinicians and nurse practitioners to the physician cost report, Part B, so that we can bill for our services and not be on the hospital cost report. Elizabeth, next slide. All right, so this is the slide I told you I would talk about in terms of clinical documentation. At the end of the day, the overarching criteria for which payment for your services is based is on medical necessity, and that comes from clinical documentation. As a healthcare clinician, if you are coding for your own services, or even if you have a coder who codes for your services, at the end of the day, you alone will be held responsible for the documentation and the code that was billed for your services. When you submit a bill, you are certifying and attesting that the services were medically necessary and complied with payer billing guidelines. So it's clinical documentation really is so important, because at the end of the day, it really drives your CPT code, which I'll get into in a minute, and your ICD-10 code. And it supports medical necessity for that service that you provided to that patient. Clinical documentation also serves as communication. I stress it enough with my clinicians that it is communication to the patient. Patients can see your notes now, right? They have access in Epic or Cerner to go in and view those notes in real time. You need to make sure that what you're documenting, the patient can clearly understand what's going on with them. It's communication to the payer, like I just talked about, and it's communication to another clinician of the story of that patient and what is going on with that patient. So important. Also shows your quality of care, because we all give great care to our patients. It reduces any risk management exposure. And at the end of the day, we're all here today talking about it. It ensures that you get reimbursed for the services that you provided. So I can't stress enough how important clinical documentation is. Next slide, Elizabeth. All right, coding 101. Now, I could have a whole lecture on how to code, but that's not what I'm here to do. I'm here to really talk about the different components of coding. So there are, I look at them in 4 categories. There's your CPT, which I'm sure many of you know about, which is your current procedural terminology, ICD-10 diagnosis, HCPCS, which is your healthcare common procedural coding system, and hierarchical condition category coding, which is HCC. So I'm going to talk about each one really high level. So CPT, that's maintained and developed and published annually by the American Medical Association. And it basically, it'll come out soon. Around Thanksgiving, they'll publish all the updates to the CPT codes around Thanksgiving. And it helps identify a service that was provided, and really provides a uniform language to coders, auditors, payers, and clinicians of what was done to that patient. CPT improves reporting, and it increases accuracy and efficiency when it comes to clinical documentation and coding. CPT to me is the what. What did you do to that patient? This is your evaluation and management services, your surgical procedure, and your diagnostics. ICD-10 is the why. Again, your clinical documentation drives your ICD-10 diagnosis code. All claims require a diagnosis code, because again, your diagnosis code supports the medical necessity for the what, right? It's the why. You need to make sure that when you're seeing a patient, you're documenting all of the conditions that you're evaluating, managing, assessing, and treating. ICD-10 is extremely important, and it's becoming more important because of HCC coding, which I'll talk about in a minute. CPT codes, you have a CPT code, it's tied to a specific work RVU value, which is tied to a specific revenue or reimbursement value. ICD-10, I'll talk about how that ties to reimbursement in a minute. Next slide, Elizabeth. HCPCS coding, this is similar to CPT in that, again, it has a standardized code set. It has medical procedures that you bill the federal government for. This is where your DME supplies are. These are where your pharmaceutical drugs are any sorts of products or non-physician services are in the HCPCS book, and they are updated quarterly. Again, you have a code and you have a value tied to that, or revenue value tied to that code. HCC coding. This is your risk adjustment methodology. HCC codes determine how much money you get paid for taking care of those value-based reimbursement patients. So your Medicare Advantage patients. Any value-based plan is related to HCC coding. What makes an HCC code is driven off of your ICD-10 code. This is why ICD-10 is so important, because your ICD-10 basically helps with determining the medical severity of your patients, which in turn determines how much money you'll get paid for taking care of those patients. And again, clinical documentation drives your ICD-10, which drives your HCC. Historically, the OIG has focused on CPT and HCPCS codes because there was a financial value tied to those. HCC has gotten heightened scrutiny from the OIG because of this value-based, this revenue attachment related to payments for patients. So there's increased scrutiny from the OIG related to HCC coding. It is number 2 on their work plan item this year. And just, again, really important for you to understand how those of you, especially that have a value-based reimbursement model in the primary care setting or even in specialty care settings, how your diagnosis code drives the HCC code, which then drives how much money, on the back end you're getting to take care of those patients. Again, I could talk a long time about how to code. I'm not going to do that today, but there's a lot that goes into it. But really high level, those are the 4 coding sets that you should be aware of when it comes to reimbursement. Now I'm going to tie it all together. Elizabeth, next slide. All right, so the 3 ways as a nurse practitioner you can bill for your services. Incident 2, split share, and the easiest way and most least risk when it comes from a compliance standpoint is directly bill for your services. So incident 2, it's a Medicare regulation, but tons of federal and commercial payers follow Medicare's regulation. Medicare defines incident 2 services as those furnished incident 2 physician professional services in the physician's office or in the patient's home. So these are services provided in a physician office or place of service 11. What it means is the physician puts the plan of care together for the patient and outlines all what needs to be done with the patient from a plan of care, and the nurse practitioner basically follows that plan of care. And then when that nurse practitioner sees that patient, they bill under that physician's NPI number. Now I'm going to get even more into the weeds. There is a lot of restrictions around incident 2, which makes it really hard to follow from a compliance standpoint. So let's talk about this. The nurse practitioner has to be in the same group as the physician, the same physician practice or group. The physician has to be in the office to provide direct supervision and be immediately available. This doesn't mean they can be in the OR doing surgery. This doesn't mean they can be across the street grabbing a cup of coffee. This doesn't mean that it has to be the physician that's on your collaborating agreement. It means it has to be the physician that's in the office when you are providing this service to this patient. So what does it also mean? So it also means that this incident 2 cannot be done in a hospital or facility setting, only a physician office. Incident 2 cannot be done on a new patient, because a physician hasn't seen that patient to establish a plan of care related to that patient. It cannot be done on an established patient with a new problem, because again, has the physician put up a plan of care related to that problem? No. So incident 2 is very restrictive in terms of how you can practice as a nurse practitioner. It's an established patient with an established plan that a physician has outlined. Now, the physician still has to provide, still see that patient in regular intervals to be, again, to meet incident 2 guidelines per Medicare. And again, at the end of the day, if all of these steps are met, you as a nurse practitioner can bill under the physician's NPI number. I would encourage you to attest that you were directly supervised by, say, Dr. Y. And although it's not a Medicare requirement that a physician signs that note, if you were to be audited, you need some way to prove how the physician was in that office during or in your office while you were providing these services. So again, really important and very restrictive when it comes to billing incident 2. That's incident 2. Split shared. So split shared definition changed in 2022 when the Medicare changed the regulation around split shared billing. So the definition now is a split shared is an E&M visit defined by Medicare Part B payment policy as a medically necessary encounter with a patient where the physician and a qualified nurse practitioner each personally perform a substantive portion of an E&M visit face-to-face with the same patient on the same date of service. A substantive portion of an E&M visit involves all or some portion of the history, exam, or medical decision-making key components of an E&M service. The physician and the qualified MPP or nurse practitioner must be in the same group practice or be employed by the same provider. This is what split share can be done in a hospital-based setting. So this is your provider-based clinics, your hospital outpatient departments, your emergency department, your inpatient setting. It can be done with any evaluation and management visit, even critical care. So critical care, you could never do a split shared service with until 2022. Now you can do split shared with critical care. The substantive portion. So what does this mean? Again, it means whatever clinician documented and performed a more substantive portion of that visit. Either it's the HPI, the physical exam, or medical decision-making. Or like for critical care, if you're going to bill on time, you take the physician's time, you take the nurse practitioner's time, you add it together, and whoever had greater than 50% of that total time would be the billing provider. Now, those of us who know how the rules and regs changed in 21 and 23 from an E&M standpoint, right? It's either medical decision-making or time. Those of us in the compliance world, we've kind of leaned to say the substantive portion should be medical decision-making. So whichever clinician ends up documenting a more robust medical decision-making or captures more of those components that make up medical decision-making, then that would be the billing provider. And of course, Medicare added a modifier to differentiate this E&M from other E&Ms. Now, you may be asking yourself, what about 2024? There was rumor out there that split shared would totally change to just being based on time from a billing provider standpoint. But with the pushback from all of the physician healthcare organizations, Medicare, it seems, probably will delay it again another year. And so I think substantive portion based on your 3 E&M components will still be a way that you can capture your split shared services even come 2024. And I'm sure they'll continue to evaluate it. And finally, direct billing. Again, this is where you bill for your services directly. You want to make sure you're credentialed with your payer, that you're billing for services that are within your scope of practice. Obviously, that you saw the patient on your own and provided that service independently, and it would be billed underneath your NPI number. And that is it for my portion. I'm going to turn it over to Lisa, who's going to talk about the regulatory environment when it comes to reimbursement. Lisa, it's all you.
Great. Well, thank you, Carrie. And thank you for that presentation too. I enjoyed having a little bit of a reminder, particularly of compliance issues, which are really important. So, and welcome to all of you. I lead regulatory and policy work at the American Nurses Association, and we focus quite a bit on federal policies as they relate to payment for nursing care. So next. So I'm going to use our time today to examine several key policies that determine how advanced practice registered nurses are paid. And I really should say, after Carrie reminded me, to determine how the services of advanced practice registered nurses are paid, because I'm really going to be focusing on direct billing quite a bit. Next. We'll also point out as we go that opportunities for APRN payment advocacy and some tools that can help us reach policy goals. And we will be focusing primarily on the Medicare program. Medicare is not the only space for nurse advocacy on payment. However, the program covers 65 million people under rules that are subject to public input. So Medicare policy is a place where many voices of nurses can have significant impact. And it's important to know the parts of the program that we want to change or keep the same as the case may be. Next. So I'd like to start by clarifying terms that I will use. You may already be familiar with these terms, and they all relate to healthcare payment. But their meanings really do differ for policy purposes. For instance, a health purchaser is not necessarily the same as a healthcare payer. And there are different methods by which practitioners receive payment for the care they provide, and Carrie just identified those main three. Next. One more time. Yes. The term purchaser usually refers to a sponsor of covered groups. For example, you can think of Medicare as a purchaser at times. Another example is a large employer or a state employee benefit system. And purchasers buy coverage or access to care on behalf of groups. They're often concerned mostly about overall costs and the quality of the services they are buying on behalf of the people they are buying for. Next. Now, we often use the term payer referring to a direct source of provider payments. So Medicare fee-for-service can be considered a payer. So is an insurance plan or managed care organization. And again, next. And payers use various methods of paying, but mainly two or three. First is direct reimbursement, as Medicare fee-for-service pays units of payment for units of service. Then there's capitated payment, an amount set out before any services are provided that estimates the cost of care, for instance, on a per patient, per month basis. And some prevention and disease management programs and health homes are other examples where capitated methods could be used. And you may also have heard of value-based payment. Carrie touched upon that. And that could be a quality bonus. It could be shared savings or shared risk. And value-based methods are often built on a fee-for-service or a capitated approach. Next. And these terms can overlap at times. However, I often find that they're used interchangeably, which can be confusing. And again, we want to be as clear as possible about the policies and payment mechanisms that we want to change. The end goal is to improve APRN's position in care delivery and financing. Next. So when I get involved in detailed discussions about Medicare payment policy, I do marvel at the complexities, and I'm drawn to the challenges of interpretation. Yet sometimes I just want to call time out and ask, is there a patient in here somewhere? Well, of course, patients are at the center, and nurses are there too, right with them. So I just include this image for a little break as a reminder of what we care about. Now, next, back to payment policy. Consider as a starting point the sources of Medicare payment policy. First, there is legislation. Title 18 of the Social Security Act, first enacted in 1965 and oft amended. Then there is implementation and administration. And today it's the Centers for Medicare and Medicaid Services, or CMS, that implements or administers Medicare program, or in Title 18. And it does so in two ways, by regulation and through contracts with third parties. So CMS creates regulations on matters such as coverage, reimbursement, provider eligibility, quality oversight, and more. And CMS also administers contracts, some grant programs as well. For our purposes, though, we're looking at the large contracts with payers such as Medicare Advantage companies. Next. But now we're going to go from that 10,000-foot view to the microscopic and look at the parts of a Medicare fee. In fee-for-service, reimbursement starts with a billing code, often a CPT code or a code that CMS creates. For that code, the fee consists first of three values that have separate data points. First, there is the work component. That is the practitioner's time and skill and judgment, and this makes up about 51% of a service or procedure's valuation. Second, there is a practice expense component. This reflects the cost of supplies, clinical staff, including RN time, overhead, and so on. And that's about 45% of a fee or valuation. And the rest is based on estimates of liability insurance costs, which we're not going to cover at all today. So CMS takes those three values, puts them in a blender with its own recipe of common factors that have to do with prices, wages, and so on. And then the result of applying these factors to the values is the dollar amount that CMS pays for that code in a given year. And annual fee updates are determined by CMS through fee schedule rulemaking, which Carrie also mentioned, and I'll get to in a little more depth in a moment. First, though, we need to ask where CMS gets the work and practice expense values, because that is where nurses can play a role. Next. In order to assign work and practice expense values to each coded service, CMS relies on an influential expert panel. This is the Relative Value Update Committee, or RUC. I'll say RUC, comprised of 19 members who are practitioners in Medicare. And the RUC meets 3 times a year to consider and vote on values for selected codes, which then are forwarded to CMS as formal RUC recommendations. Now, finally, we get to a key point. When deliberating, the RUC examines data from various sources, and one important source is survey data from practitioners who estimate and enter time and expenses for the selected codes. This information is presented to the RUC by advisors, including ANA representatives. And the advisors play a role, too, in interpreting that data when presenting it to the RUC. The ANA supports our advisors by surveying our members. It is very important for ANA members to take the time to complete a RUC survey if you receive one in your email inbox. A RUC survey is an important opportunity for APRNs to influence payment policy directly at the code level. And that's a core place to inform policymakers about what nurses do that might otherwise not be accounted for at all. Let's learn a little bit more about this from this short video. It's about 1.5 minutes.
Today, more than ever, your time is limited. Nursing services are vital, and we need your help. The American Nurses Association is helping APRNs advocate for their value through the American Medical Association's Relative Value Scale Update Committee Survey, better known as the RUC Survey. The survey takes into consideration the scope of APRN services in determining reimbursement. This helps identify accurate and fair payment for APRNs. If nurses don't speak up, their profession risks being excluded in valuing healthcare services. We need you to get involved. You will receive the RUC survey through email. It will ask you to estimate the amount of time needed, the intensity, and the complexity to perform a procedure based on your average experience. For example, suturing a wound. This data is presented to the RUC, which makes formal recommendations to the Centers for Medicare and Medicaid Services. CMS accepts recommendations more than 95% of the time, ensuring the correct value for APRN services. Take control of your career. Take ownership of the future of nursing. Take the RUC survey. Today, more than
There we go. So if you receive an email from ANA or other nursing society asking you to be part of the survey, please fill it out. This is how many APRNs are paid. Also, though, the practice expense part of the survey captures RN time and clinical support. A typical survey takes 20 minutes to a half an hour. The bottom line, providing input to the RUC process is a great way to show policymakers the value of nursing care. As I mentioned earlier, the RUC process is a core component of the fee schedule rulemaking. But first, I'm breaking with this slide to center the healthcare workforce, especially nurses. You are the reason we advocate at ANA. Next. The work of the RUC is seen every year in the fee schedule rule. CMS proposes this rule along with other policy ideas every summer. This year, the notice of rulemaking came out on July 13th with a public comment period that just ended on September 11th. The final rule is expected in mid-November, and the changes take effect January 1, 2024 for calendar year payment in fee-for-service. Next. The fee schedule rulemaking is another opportunity for nurses to come together and advocate for better payment policy and to comment on specific proposals. Anyone can comment through the federal website, regulations.gov. Typically, ANA comments on coding and valuation, APRN practice issues, quality measures, and RN value. This year, we submitted comments on telehealth reimbursement, quality measures that indicate nurses' value, health equity, and more. We advocated on behalf of nurses for recognition of the value of nurses and for the removal of federal practice barriers, which still remain for advanced practice registered nurses. Next. So far, we have focused today on Medicare fee-for-service. Sometimes fee-for-service is referred to as original Medicare, as distinct from Medicare Advantage, which Congress created much later. Medicare Advantage is an opt-in alternative for beneficiaries to choose a private plan that offers Medicare coverage and often additional perks. CMS enters into large contracts with Medicare Advantage companies. The companies design plans based on what Medicare covers and then enter into contracts with providers and practitioners who agree to serve Medicare patients enrolled in the plan. Referring to the definitions we reviewed earlier, a Medicare Advantage planner is a payer. In contrast to fee-for-service, the structure of plan payments to providers is not public information and not subject to stakeholder input, at least not to the same extent as we talked about a minute ago. However, CMS does have oversight authority over managed care and Medicare Advantage companies. CMS can change or add contract terms and, for example, can require plans to impanel specific provider types to meet the needs of their service area. CMS seeks input on Medicare Advantage in various ways, and this is another point of engagement for nurses. For instance, ANA has submitted comments urging CMS to promote access to APRN care for those beneficiaries who have chosen Medicare Advantage. Next slide. And this brings me to our last topic, which is advocacy to address plan discrimination against providers and provider types. Federal law actually prohibits promotes APRN participation in plan networks. Specifically, the Affordable Care Act prohibits plans from discriminating against a provider acting within their scope of practice. The trouble is there are no regulations and there's been virtually no enforcement of this provision. In 2020, Congress directed CMS and other agencies to write one set of regulations clarifying what plans can and can't do under this non-discrimination provision. The regulation remains overdue, long overdue. When the proposed rule is released, this will be another opportunity for nurses to advocate for APRN value through public comment. And I do want to note that the provider non-discrimination prohibition does not apply to providers and health systems. And so APRNs often encounter hospitals or other employers that refuse to credential them, even if they have full practice authority in their state. And this law wouldn't stop that. But we do think if plans open up, then that will have some impact on hiring and credentialing and how how service delivery is organized at the provider level. Next slide. So that's been a lot of information, and I really want to thank you for listening and staying with me. And I want you to have two takeaways. First, there are multiple policy paths to understand payments to APRNs and for APRN care. And therefore, there are multiple opportunities for nurses to engage, inform policy, and advocate. Today, we looked at participating in the RUC process and making nurses' voices heard when payment regulations are proposed. And I know there is the advocacy that you are doing and can do where you are practicing.